Thank you very much, everyone, for having me to speak to your group again. I know a lot of you, and it's old friendships that we're going to capitalize on, because my talk today is going to be a slightly different presentation than the usual talks on Parkinson's disease treatment and a very monochromatic approach. What I'm going to do today is first present to you what is becoming a disease almost of humanity and human development. So let's see how we can tackle this in terms of how our growth as humanity, in the first few slides, then we'll get to the usual Parkinson's disease treatment talk again, how technology has impacted what has happened in terms of neurodegenerative disease. In the first few slides, we're going to tackle that. In terms of causation, environmental causes, diagnosis, in terms of genetics and imaging, and also treatment. The reason I'm talking about this is because, being an MIT grad, technology has been very big in what I do, and we've developed a lot of interesting, innovative technologies in terms of how to assess, potentially diagnose, and even optimize treatment. So it's that marriage of how, as humanity, we've developed, how we started using technology, how that may have affected disease as we see today in our world, and what we're doing positively in using that same technological advancement to help us in management of diseases like Parkinson's disease. All right, so let's see that. Lots of effort has been put in the last little while looking at what we call at-risk groups. And the question is obvious: why did I get the disease? And I get that asked every time. I look after now about 3,500 Parkinson's patients in my practice between here and Thunder Bay in southwestern Ontario. It's funny because now we regularly get patients that are from the north of Ontario. So on Tuesday, out of the 9 patients we saw, 5 were from Sudbury, Timmins, North Bay, et cetera, et cetera. So the catchment is very large, and hence our volumes are very big. But the commonality of the question is still this: why did I get it? Well, that's a difficult answer. And so what we're going to talk about briefly is exposure, so environmental things, maybe sleep dysfunction. We know that something like REM behavior disorder, that is, acting out of your dreams during sleep, may be an indicator of degenerative disease, Parkinson's being one of them. Early smell loss could also be an indicator. That could be because of exposure. It could be just simply because of your genetics. Significant constipation and slowing down of body systems could be related to our dietary intake over the last several thousand years. More meat eating, less meat eating, more vegetables, etc. Family history, which is our genetics, and then infections. We're not going to talk about all of them, but first, just for a little while, we're going to digress the first few slides and talk about how, as I said, our development as a society and development as a technological society has potentially, and this is just hypothesis, changed or taken us into a direction of neurodegenerative disease. One, and the biggest variable, is survival, right? So 2,000 years ago, the average lifespan being 25, you never saw neurodegenerative disease, right? Now, our lifespan being a lot longer, many of these things will have an impact on how our systems are able to adapt. We were talking back there a little while ago on plasticity, change in our system. Well, if you only had 5 minutes of change that you required, nothing much would be required. But because we're now living a lot longer, adaptation to environmental exposure, to how we have lived as a society, do make a difference. So, since Roman times, these are just examples, and this, as I say, is my obtuse interest, but I thought since most of you are my friends now, I might as well share some of these interests with you, because these are important things that have happened to society and intriguing to think about, right? So, as you know, Romans became gradually encephalopathic and died as a civilization. One of the causes was related to the lead poisoning that they sustained from pipes that were brought. This is a civilization that grew dramatically, as we know, 2,000 years ago, and has given us so much in terms of our culture. Many people traveled to Rome because of all the cultural advances that they made, but at the same time not knowing that an environmental exposure, like bringing water from distances in lead pipes, was toxic to them. A large number of people died, including Nero burning Rome, of encephalopathy people feel related to lead poisoning, causing a sleep disorder and vivid dreaming. Right? We know today that REM behavior disorder, as we talked briefly for a couple of seconds, could be related to the early onset of degeneration. Well, is it possible that such neurodegenerative changes that occurred in those Roman times are or could be related to how we simply even bring water to our homes. This has been talked about in terms of well water drinking, right? So we'll talk about that right here, and then we'll talk about insecticides in a second. There's a lot of data that exists that pulling water through wells in the ground, which may have collected things such as insecticides, which we'll talk about in a second, may have a causative factor in determination of Parkinson's disease. So rural living, people that are drinking well water, are at a higher risk of development of neurodegenerative disease, Parkinson's being one of them. Well, we have historical evidence that even from that time where industrial improvements that occurred in water bringing, aluminum about 30, 40 years ago was also talked about in terms of deposition in Alzheimer's disease. Right? So, intriguing thought. The Sumerians in 4500 BC first started using pesticides. Before that, cultivation did not require using pesticides. We are now gradually swinging in a few percentage of these organic cultivations to not using pesticides. Well, organic pesticides were first used post-industrial revolution and then extensively and fairly without inhibition since that time. In addition to that, coal and other combustion products led to use of organic pesticides, much more so in farmlands. Right? Those pesticides stay in the farmland over hundreds of years, right, and are not removed very easily for another hundreds of years. So it is possible, again, that in microscopic quantities, let's tie those two things together. We've got extensive use of insecticide, pesticides, coal mining, etc., that is now moved into the earth as we've extracted these chemicals and put them back in a modified format. Well water drinking is now occurring using water from the same kind of soil. Now you've got A plus B. Okay? Together, this increases the risk of our systems to be exposed to toxicity. I'm not saying that these are all obvious causations. This is simply a trek through. Why? Because those first few things that I showed you in terms of smell loss, sleep dysfunction, as well as exposure, are important because as a society, this is where we have come. Well water drinking, farming, I tied that together in this slide, but I already talked about it. Oldest wells, about 8,500 BC. It's an interesting fact historically anyway. And most of them were at that point hand dug. What does that mean? That means that the wells collected water from the environment, but they were only this deep. So the ability to draw from deep and different types of soils was not there. So people collected water transiently, as I'm collecting today from this massive torrential rain, and we're going to use it right away. When we have water accumulation and sedimentary or deposition of water, including these neurochemicals that are supposedly potentially toxic over time, and then you take that water out many years later, deeper wells, rural wells, larger quantities of water, irrigation using that water, now you have a higher potential risk. Again, small, but A plus B plus C. Additive in terms of allowing us to grow more food, increasing our longevity, but at the same time allowing us, or unfortunately allowing us, a higher exposure to potentially what could have been a minimal exposure when our lifespan was very short. Okay? All of these were great innovations and changed how we consumed water, how we grew food, etc., but also changed our longevity and exposure risk. Right? So this is not all my invention. This is from the literature. Right? Manganese and mining and welding. This wouldn't have been an issue during times 5,000 years ago, or 3,000 years ago, or even recently until 1,000 years ago during the medieval times, because manganese mining and welding was not prevalent. Had been used in paintings about 30,000 years ago, but it wasn't done at an industrial level. Manganese is used not only in welding, in steel and iron industry, but it's also used in many plant fertilizers, in arc welding, and exposure, as we became more industrial, increased quite dramatically. Right? Not just in terms of consumption out of pots that are used with manganese welding. This is actually exposure to manganese mines and manganese in terms of fumes when you're doing welding actively, arc welding. Again, industrial revolution in the last couple of hundred years, an exposure A plus B plus C plus D. Just add those things in your mind as we're now in an environment where there is fertilizer use, significant insecticide use, we're digging deeper into the wells, coal mining, manganese, other such factors that are changing in our environment, largely uncontrolled because we didn't know the impact, like smoking. And my father was in the Air Force, fought numerous missions and battles, and regularly, as part of his ration in the old days, was a package of cigarettes. That wouldn't be allowed anymore, right? So those days, nobody really thought that this was going to be a carcinogen. So carbon monoxide was the same. Industrial revolution and car usage, internal combustion engines. And since then, we started seeing carbon monoxide-related neurotoxicity and acute Parkinsonism that occurred in people that were exposed in garages that were not well ventilated. None of these are acute causes of Parkinson's disease today. We don't see necessarily any of the idiopathic Parkinson's patients being specifically exposed, but there's ample data out there, individuals with manganese toxicity. I have written letters for workman's compensation for people here in the US for this carbon monoxide poisoning. Many of us have seen cases where acute carbon monoxide poisoning has caused Parkinsonism. Again, this is the addition of things, A plus B plus C plus D plus E. All of these factors that have occurred in the last 200-300 years that have allowed us exposure more and more to little fractions of things. Overall, our quality of life has improved dramatically. I wouldn't have been able to make it here today if I was riding my horse. But at the same time, I had to use my car. But at the same time, that technology intervention has created an exposure that otherwise wouldn't have existed. Not that necessarily horses didn't have carbon monoxide, but, right? Light bulbs, sleep patterns, our daily routines. People used to go to sleep when the sun went down. Our neural chemistry, which is, say, dependent on cortisol release. Early morning at 5 o'clock, your cortisol release is much higher, right? Your cardiac rate is much higher at that time. Exercise is best done in the morning, even though the cardiovascular risk of having a heart attack or stroke is slightly higher in the morning because of that cortisol release and higher heart rate. It is better to do workouts in the morning because you use your body's neurochemistry. Now I change my clock. I've been on call all weekend. I slept 3 hours the entire weekend, right? I'm on call today, right here. So, because of this, my sleep patterns are completely off. Right? It's very difficult for me to have a regular sleep pattern, where our bulbs, which have been only really used commercially for about 100 years, have changed our sleep-wake cycle. That changes chemistry acutely, but it takes a lot of adaptation, neuroplasticity, over hundreds of years of exposure for us to then gradually adapt from an evolutionary pressure. That's not what has happened to our society in the last 200-300 years. We've had all of these exposures that I've talked about in a very short time, compared with potentially 30 to 50,000 years of human development. Homo sapiens have been around probably for about 100,000 years, right, in terms of how we are today. Right? So this acute change, as we were talking earlier with Barry, does not allow our genetic system to adapt to these environmental exposures very acutely. We're still carrying genes that were from when we were 100,000 years ago. Yet at the same time, our longevity, our exposure to these things has changed dramatically. So, very brief little things. There are many such things that we can talk about, but the brush of technology with human development has increased our longevity, but has made our genetic systems susceptible to exposure, rapid change, without allowing us enough time yet for adaptation. This is a social phenomenon, right? You don't want to take an aircraft and go into the bush in Africa where people are still using sticks to start fire. This is not how technological advancement should be in terms of intervention in a society. Well, we've had that happen globally. I didn't mention all of those things because they're simply random thoughts in my mind. Many of these have been considered and are actively being pursued in groups like mine and others, collecting large cohorts of data as to what it is in terms of exposure to the environmental factors like well water drinking, insecticide, pesticides, etc., that have led to that at-risk syndrome. You know what I mean? So here's a scenario. If that person asks me, why did I get it? Well, if you're a person that works in a manganese mine, maybe has had exposure to insecticide, pesticides, lives in the rural countryside, drinks well water, has had a family history of Parkinson's disease, well, guess what? You are at risk, right? Because each of those little factors may be additive in terms of neurodegenerative disease. Not longevity, that might still continue on, but neurodegenerative disease. This is, again, not a concept that I'm just putting forward here. Large databases from the National Parkinson Foundation, Parkinson's Disease Society in the US and other European societies have been collecting data, as are we, as part of the Ontario Brain Institute, to try and understand the topology of what it is that causes neurodegenerative disease in various illnesses. So we have this database. In fact, there's a conference going on right now at the Ivy Center where ALS, stroke, Parkinson's disease, and a couple of others, vascular disease. We're collecting data as part of an Ontario initiative to try and understand this blanket, this breadth of what the at-risk syndrome may be as one of the questions. Is early balance difficulty a predictor? Is the fact that you have osteoarthritis or low vitamin D levels early, is that a biomarker, right? The reason for all of these studies and biomarkers are, if we identify somebody at risk, like that individual, say, maybe that's when and if I have an intervention, such as aggressive exercise, such as dance therapy, who knows? Might be that individual is the individual that you need to intervene aggressively. Preemptively give things such as maybe coenzyme Q10 if it had worked, or any other drug intervention to prevent and change that trajectory from neurodegeneration to a healthier life. See, that's the construct behind this. The flip side of this is that we can use technology in terms of diagnosis and treatment of Parkinson's disease. So we're going to switch over from etiology and causation, as I talked about briefly, to understanding Parkinson's disease. Can we use biomarkers? And I've given you a little bit of lead-in already in terms of the kinds of things that a patient presents, their template. They come to me and say, well, I'm 72, I have an aunt and an uncle with Parkinson's disease, I lost my sense of smell 10, 12 years ago. Yes, I've got lots of constipation, or maybe I don't. Yeah, I was living up north where manganese mines were. Now I have a canvas upon which the person has a neurodegenerative state on which I can say, okay, and I have this person, I'm going to look at them with a different viewpoint. Right? Then what do we do in terms of diagnosis after that? Well, technology comes in there as well. Let's talk about genetics. In the last, probably 15 years or so, especially in the last decade now, almost all, and then recently with the Human Genome Project, all the genes of the human genome have now been mapped. We have no idea what they do, but we've mapped them anyway, right? As you know, we share 99.5% homology to chimpanzee, so exactly the same genome as a chimpanzee, but we're different. What does that tell you? It tells you that even that small variation in the genetic makeup makes the phenotype of what we are extremely different, right? So if you take those 30,000 genes, all of you look different, but you all have exactly the same genes, except for the mutations that occur during birth and all those things that occur from cellular division. We all have exactly the same genes, but none of us look the same, which means that genetic interactions that occur between those 30,000 genes are mathematically enormously complex, not linear. That means that most diseases that we know are not monogenic, single gene. That means that I have one gene mutation, I get the same disease. Not the case. Even those diseases like Huntington's, which are well known to be related to one single gene on chromosome 4, present completely differently. So, just because you have a genetic predisposition, and we can now identify two genes, the so-called LRRK, unfortunately I can't point to anything with this, but the LRRK2 mutations, LRRK2 that you'll see, two potential genes, and the synuclein mutations. These are, you don't have to remember this, but these are two mutations that are felt to be potentially another at-risk factor. Right? So we've got all of these at-risk factors. Now I do your genetics, and I see, oh, you've got not a Parkinson's disease phenotype, but an LRRK2 gene mutation. Adds to your A plus B plus C plus D, and now I've got a genetic E on top of that. Does that mean you're going to get the disease? Unfortunately, we don't know that, which is why we cannot diagnose Parkinson's disease simply by doing genetics. Once you get the disease, and we can go back and diagnose genetically, sure, but that doesn't really help now, does it? Because I can already tell you've got the disease. We want to be able to go here. So, at the moment, genetic identification and the technology that exists does allow us to identify the genes but not causation. So we don't do genetic tests for patients with Parkinson's disease unless you have a very strong family history and say, yes, my mother and my mother's aunt and cousin and 3 other people in the family had this disease. Then your at-risk level becomes that much higher from the genetic perspective, and I can now go test you, maybe even the family. One little side digression, there's a particular mutation for Gaucher's disease, which is an enzyme called glucocerebrosidase. Long word, we'll have you spell it backwards when I'm finished. And that particular mutation puts patients at risk for getting Parkinson's disease much higher than even the others. And this is a long story, but cut it very short, has led to trying to take patients with Parkinson's disease, even though they may not have a mutation in that gene of Gaucher's disease, because most Parkinson's patients don't have. It's a different disease, Gaucher's. Right? But patients with Gaucher's disease can have a higher chance of getting Parkinsonism. That doesn't mean that patients with Parkinson's disease have Gaucher's disease, you see? So A doesn't map to B. It's not bilateral like this. It's this way. But based on this idea, one of my colleagues, Dr. Steve Pasternak, and I have, along with a couple of other colleagues, started a clinical trial of treatment of patients using a drug that increases glucocerebrosidase in the brains of Parkinson patients, at least theoretically. And that drug is, I say I can't point to anything, so I feel pretty weird here, but there's no way to have a little mousy thing, right, for me to point? I can't, nothing to point. Does this have a pointer? But anyway. So if you look here, there's something called Ambroxol. Can you see that? Ambroxol? Ambroxol. Ambroxol actually is a cough syrup, believe it or not. And it's available over the counter in England, but not in Canada. So we're having to import it at enormous cost. I mean, it looks really stupid for us to pay $500,000 for a cough syrup. But that's what it's costing us to bring this into Canada. And we've just started this trial. It's been Health Canada approved, et cetera, to treat patients with Parkinson's disease who have mild cognitive impairment, not motor symptoms, because it's only a 1-year pilot study. And we're beginning this study, well, we have just started this study, actually. And we're enrolling for that study patients, and many of you who are part of my clinic will hear about this as we get going, to increase this enzymatic level of glucocerebrosidase. It's a therapeutic intervention. Why? Because the other 2 genes that are there in line number 2, the LRRK2 and synuclein mutations, we don't have a therapeutic intervention. So the idea is that technology and our availability of being able to test for Gaucher's disease, which led to us understanding that there's a slightly higher risk of Parkinson's in that population, just like Alzheimer's is there in Down syndrome. So patients with Down syndrome have a much higher risk of getting Alzheimer-like pathology in their brain. Same thing is true here, and hence we're going to reverse that and take patients with Parkinson's disease who don't have Gaucher's disease, but based on that logic, and we're going to give them Ambroxol. So see how that technological advancement through Gaucher's, brilliant. Does it work? This technology doesn't work. Sorry, I'm pressing the wrong thing. That's the reason why. This is just a mark. Okay, I got it. Figured it out. Okay, all those years at university. I can use a pointer. Okay, so again, I think this last point, actually, believe it or not, is very important. What does it mean to get tested? Because the first question people ask me is, why did I get it? The second part of it is it genetic? Will I pass it on? Did some of my children get it? And the answer to that is obviously no. At this point in time, we're not telling anybody that we are testing for Parkinson's disease unless you are in that at risk, where you have lots of family members, right? So this is important because at the moment, testing is not good because we don't have any preventative treatment. There's social stigma. Even if you find out that you've got an LRRK2 gene mutation, as I said, it doesn't mean you're going to get disease. Hence, testing is not recommended for Parkinson's disease in anyone. Unless, as I said, there's a very strong family genetic tree and we want to do it as research. And we already talked about this already, restricted to strong family, young onset, maybe personal issues, kids, etc. But even in monogenic diseases that we talked about, like Huntington's, where there's one gene and you can identify it that's clean, even then, about 30% of carriers at risk will not want testing. Right? So with Parkinson's disease, even less. It's less than 5-8%, so we would not recommend testing. Right? So it means that individual genetic contributions, as we've talked about with all those genes, cannot be used for causation. They simply put you potentially at risk. Okay? Imaging, which is another technology. See, I'm just trying to stick to that tech theme. Currently, at the moment, there are no accepted imaging techniques for diagnosis of Parkinson's disease. For years, one of my predecessors here, who's a clinician scientist like me, Dr. John Stossel, that some of you might have known, has done lifetime work on PET scans, which are scans where we give a dye that specifically, it's not a dye, it's actually something that binds to the neurons that are responsible for dopamine in the brain. We give that particular binding agent and you can image those brain cells. The problem is the positive predictive value, which means the ability to predict disease, is really poor early in disease and improves dramatically at the end or late part of disease. But by that time, I can already tell long before that the patients have Parkinson's disease, so it doesn't really help us. So at this point in time, the variability in the PET scan imaging when you don't have confirmed 5 years of disease is very high. So as a diagnostic test, PET scans cannot really be done or shouldn't be done, and they have remained in the last 30 years essentially a research tool. There's another scan called the DAT scan available, and there are several types of DAT scans, and they are actually commercially available in the US. Same problem. Early in disease for diagnosis, a lot of variability. Later in disease, when disease is confirmed by the clinician and the doctor by examining the patient, the scans are positive. Well, then why waste the money doing that? Until we actually have an ability to accurately measure that biomarker from imaging, it is not yet recommended anywhere in the world really to do routine diagnostic DAT scans. So the diagnostic variability high is not used. You can see that in this DAT scan over here, which measures that dopamine, this is the normal uptake, which looks equal on both sides, and in that, which I can't point to, but the other scan, on the one side, the lump of dye is bright, the other side is very small. And at that point in time, the diagnosis of asymmetric binding of that agent, meaning Parkinson's disease, is made. So that's all that we currently have for imaging and diagnosis of Parkinson's disease. And then the third part of the talk, which is obviously one of the most interesting for everybody, is the use of technology, or I wouldn't say just technology, but technological developments that are new in terms of treatment of Parkinson's disease. And it is really all technology, believe it or not. The reason why technology is important in this phase or this stage of development of treatment is because levodopa, the drug that we have for Parkinson's disease, no matter what other intervention you have, whether it's physical therapy or speech therapy or whatever, levodopa is a home run. Right? So none of our patients can be sustained on whatever other therapy we intervene with, right? Whether it's counseling or exercise and dance, others, without this drug. It's just not possible. And the improvement in quality of life and function with dopaminergic treatment is so amazing that it's very hard to improve upon that already made home run, right? So this is one of the biggest problems that we've faced in new drug development. So what we've concentrated in our research is to try and use now the parallel technological development to optimize the treatments that already we know work really well. Levodopa is one of them. The other is DBS. So we're going to take a couple of these and talk about them as to how technology that we've developed in our lab is being used to optimize and improve the quality of life by using the drugs that already work really well. The last reason for this is developing a new molecule, not a CTV news molecule that actually is tested and validated in the laboratory. Takes at least 15 years, if not 20, of bench work, including clinical trials, and costs $1 billion, right? So development of a new product is extremely expensive from all those perspectives. And because we thankfully have good treatments, our role as a lab and as a research group has been, to some extent, at least 60-70% of our lab, has been focused on optimization of that treatment. So let's see how we're trying to do that. Okay? So deep brain stimulation, let's pick that. I'm also going to talk about the therapy briefly. Regularly performed for those who have an excellent levodopa response, which means that you have to have a response to levodopa which improves your symptoms to the level that you want to have improved. So, classic example, if somebody has bad hip disease and knee disease and is wheelchair bound because of osteoarthritis, no matter what we do with brain stimulation, ain't gonna make you walk. Right? So you've got to be able to walk because of improvement of levodopa. Right? Even with that, there are lots of complications, as some of you know who have already had this procedure here in London with us. But at the same time, goal definition and making sure that the patient's expectations are met doesn't cure the disease, doesn't change the progression of disease or any of those things. But at the same time, if we are able to tackle and address the need of the patient in terms of goals and development of improvement of quality of life based on what they want, and we're able to match that with our levodopa treatment, well, deep brain stimulation may be an option. Right? At the moment, we've got 10-year data even from our own center. We've done about 200 and some odd now over the last 15 years, and the outcome is quite good at 10 years. Much better than what medical management and oral medical therapy would have given for that patient over that 10-year period, because we usually don't do patients operatively in the OR or with DBS unless we're at a point where we're not able to optimize that treatment any further. Right? So speech, gait, balance worries are there, but motor symptoms usually respond best, and even non-motor symptoms such as anxiety can respond. Okay? So here's what we do. We put a frame on like this in the outpatient setting. The patient's awake, as you can see. It's done under local anesthesia. We do an MRI scan that gives us the stereotactic coordinates, which means the coordinates in three-dimensional space for us to take the person to the operating room, make a small hole in the skull. Patients are awake through all of this. It's local anesthetic only. A little bit of Ativan, maybe a little bit of midazolam, which are agents that make you relax a little bit, but not anesthetize the patient. And then the electrode is placed into the brain on one side. We map the brain region that we're going to put the electrode in, and then the electrode is implanted. I think that. So the next picture shows you where we go. So the two pictures there, this is actually the entirety of the coronal section, this section of the brain, surface of the brain, deep parts of the brain. So when I'm in the operating room with our neurosurgeons, we will go down about 6.5 inches, all the way down here. Down here, I think, I can't see where I'm pointing, but it's somewhere down there. You can see those black blobs that are there. Just below that, so just here, that's how deep we have to go in, right? So you can imagine that the electrode is about this big, and we have 5 electrodes that we put in on each side, map the area of the brain, and then insert that electrode once the mapping is done so that we know that we're in the right spot. This nucleus, as I said in the previous slide, is called the subthalamic nucleus, or STN. So here's what we do. You can see. Can you hear how the cells are firing? I don't think anybody's actually heard in this audience probably, but this is the real recording from a patient's subthalamic nucleus, and we map electrophysiologically by moving body part and say, yes, we're in the hand region, we're in the arm region. The person's awake, that's why we need them awake. We get them to put their hands up, do a variety of different things, and now basically in the operating room, our technicians and the surgeons do all of this mapping. When we first started this, I used to be there in the operating room, but I don't go there anymore. Once the mapping is done, now the patient is given a general anesthetic. The wires are put underneath the skin, and we put a pacemaker. Now, this is not the same as a cardiac pacemaker in terms of having the simplicity of the cardiac pacemaker, but essentially it is a brain pacemaker. Right? Patient's woken up, usually a day later. After recovery, we send them home, and then programming of this device starts. At the moment, there's a huge, as some of you that have had this, huge problem in terms of how we program, because there are many combinations between contacts of those electrodes, between the parameters that we can set, voltage and pulse width and frequency, and that requires literally programming almost on a daily basis in some of these people, and we can't do that. For patients, it's impossible. For physicians and people that are doing the programming, it's impossible. So DBS, which is already well established, produces improvements with a variety of different ways in terms of the motor functions. But the problem for us is that the technology is not allowing us to optimize these DBS parameters properly. So what we've developed is a methodology with which we put sensors on patients, and we send these sensors home. We're not doing that yet in the general clinical world, but we're doing this in the research lab, where now, instead of having the doctor sitting in front of the patient and optimizing those parameters, we can send what was in the lab that some of you have participated in our laboratory, and I think what Jessica was talking about, bringing patients to the lab is impossible, which is true, and we send this entire technology home with them. We're able to record, and I'll show you that in a second, we're able to record the biomechanical signature of patients with Parkinson's disease when they're shuffling, when they're off, when they have tremor, when they're stiff, when they've got dyskinesia. All of this remotely in the person's home. And then the idea is that I program to that state of the patient in their home as compared to bringing them to my office where, as I said, people come in all the way from Sudbury and North Bay. Well, if they've traveled 18 hours to come here, I have no idea what their Parkinson's disease state actually is and what I'm programming to. Right? So these are some new technologies that we want to talk about at the moment. But look at this. Here's the technology that we've done. You can see the video of the person underneath with Parkinson's disease, reduced arm swing on one side. You'll see how when they turn, their gait changes, and here's a little bit of gait turning difficulty, and now they're walking. This is an animation of a real patient, right, with sensors on, and you'll see a little bit of tremor when they sit down, and we'll play that video again in a second, as you can see. Yeah, and there's a little bit of tremor in the feet bilaterally. You can see that little bit of tremor. They get up and then walk. Now, this is all body-worn sensors, multi-sensors, completely wireless. Patient will carry a pager like this, which is a little data collection unit, and this already exists. I mean, we're using this regularly now in our lab, where instead of monitoring the person in my environment, we can monitor this person at home. This bodysuit up above here, one of my previous PhD students is wearing, easy to put on, is basically just a Lycra suit. In fact, I gave a talk a couple of days ago where I put the suit on and I showed in an audience how this worked. We didn't want to do that today, but I can show you the video of this. When a patient, and we are using this for DBS device optimization. We also have a new therapy that is called duodopa, which I'll talk about in a second. We're using this technology to optimize how much levodopa we're giving to the patient over time and monitor their fluctuations on-offs to make sure that during the morning or early afternoon, late evening, dyskinesia is reduced, mobility is improved, including speech and oral motor control. So in this, there's an audio recording system as well. And it's very non-intrusive because I gave this talk, as I said, to the London Health Sciences Foundation 3 days ago, and I had my suit on, this suit on, and the other suit on, and people couldn't tell that I actually was wearing anything. Well, no, that's not true. Sorry, that came out wrong. That I was wearing any sensor systems. Let's make that clear. They're different kind of talk. All right, so because of this fact of DBS programming being a nightmare, 25,000 combinations, which I can't manage, our recording system, again, technology, can record all of these things: tremor, walking, freezing, balance, speech, bradykinesia. This is basically the unified Parkinson's disease rating scale, much more objectively than a person looking at you saying, I think you're a 2, I think, out of 4, really, isn't it? And then the problem with it is that I have 3,500 patients and I've treated 10,000 over the last 25 years, but most physicians outside have no ability to examine. This is a big unmet need to the detail that we need for optimization of therapy. This is now a simple solution to be able to get the data from Windsor, from North Bay, without having the patient travel and say, okay, go to the lab, put on the suit, and do this, this, and this. I get the data and say, that's your state. You're dyskinetic in the morning and the afternoon, but not really off in the evening. I now know this rather than having a patient fill a diary out and then bring that to me, which has two problems. One, they do the diary sitting at the Tim Hortons downstairs for the last week, not during the week. And second, I have to read through 50 pieces of paper of diaries, which I can't tell what is going on because you've got all these X's and Y. No. This gives us an objective readout. And look at this. Here's the same patient that goes from having tremor in this video to dyskinesia to an off walking state. You can see that there's tremor in the one arm, there's difficulty in walking, arm swing is reduced on that side. All these states monitored over time are in the same patient. Right? So this technology is not millions of dollars. This technology has reached a point where it is very affordable, washable. In fact, the graduate students basically take the sensors off, put it in their washing machine, and it's clean the next day. Reusable, allowing us to not necessarily develop a new treatment, but allow us, as experts sitting in London, optimize treatments for those thousands of people outside that are not being optimized, whether it's DBS that we're doing or simply oral medical intervention. Right? In fact, the International Movement Disorder Society, the MDS, and I sit on the steering committee for technology development, had our first meeting in San Diego in July to say, how can we use these technologies to optimize all of the treatments? First time that a clinical group such as the MDS is now using or beginning to use technology for optimization, not just in the lab. That's been done for many years. Right? Camera systems, et cetera, which are not portable. Okay? And there are already a couple of companies. The one that we use is an animation software company. In fact, this company, Animazoo, their technology was used for making that Panda Bear movie. I've forgotten the name. Kung Fu Panda? Yeah. So Disney buys their suits regularly, and other companies, including the military, use this biotechnology, sensor technology, to be able to, see how, in sports it's commonly used, how you throw a ball or pitch or hit the bat, these sensor technology. We've used them now for Parkinson's disease. We've studied 20 patients with DBS, and we're doing lots of other projects with this. Okay. We're now using the same technology to optimize this new therapy. I know we're running out of time, but a few more slides, not many. Duodopa is a new intestinal infusion system that has come to market in Canada over the last year. We've done 5 patients over the last 6 months or so. This technology does not use a new medication. Again, a new technological advance that takes advantage of the response of levodopa in improvement of quality of life of patients and says, either I can develop a new molecule or I can optimize what? The delivery of a medicine that already works. Hence, Duodopa. This is a gel pack that is attached as a cassette, you'll see down here, with a pump, and then connected to a tube that is put into the small intestine, the jejunum, which is where dopamine is absorbed anyway, right? So that's where the oral levodopa is absorbed, which means that when you take oral levodopa by mouth, it doesn't get absorbed under your tongue. So don't buy things that people tell you that dissolve under the tongue and be absorbed there. It's not absorbed under the tongue because the receptors that are required to absorb levodopa are in the small bowel. So you have to get the medicine all the way down through the esophagus, through the stomach, and all the little lining of the stomach, through the duodenum into the jejunum, and that's where it's absorbed, in a small part. This is the reason why I tell patients, can't eat proteins with the drug. Why? Because proteins are also absorbed in the same part. Levodopa is also a protein. So when you have many proteins sitting there in the jejunum at the same time, interference. You've got to wait an hour at least after taking your levodopa to eat anything that has protein, milk, cheese, eggs, etc. But that small part of the bowel where it's absorbed, well, the drug has to get there, isn't it? If it's stuck under the gum over here, it's not getting there, right? So, yeah. If it passes past that jejunal region, it's not going to be absorbed either. So I have physician colleagues, even in London, I'm sorry to say, who have given levodopa to their Parkinson's patients rectally. No. Change your doctor, right? Yeah. Doesn't work. Doesn't go up that way, as far as I know anyway. So the you'll have a really mobile toilet, but other than that, nothing else, right? So levodopa has to be taken by mouth, right? No wafers, no nothing. It has to. So to avoid the fluctuations of oral delivery, this system has been developed for those people that actually are taking 7, 8, 10 times levodopa every 2 hours, every hour and a half, because they have fluctuations and are probably not candidates for DBS. Well, we cannot do anything in the brain. We cannot infuse levodopa in the brain. That's been tried. Doesn't work. We can give it into the intestine through this pump, and this tube, this catheter, goes all the way into the jejunum, and it's a 4-to-1 gel suspension. The ambulatory pump provides this continuous per minute levodopa delivery, which means you can eat anytime you want, really, because in a minute you're going to get another dose, in a minute you're going to get another dose, and it continues like this. In Europe, they do a test by putting an NG tube and bringing people into hospital for a week and then giving it through the NG tube to make sure it's going to work. We don't do that. We go straight to the pump because it's a long-winded thing and it's not really necessary. So this duodopa, however, has the same problem. And this is the jejunum, just another diagram to show you how far that coil actually goes. And it goes all the way down to the jejunum. There are 3, so the esophagus, stomach, all the way down into the jejunum. I think I'm pointing to the right thing. And then here's the pump that you wear. The cassette lasts for about 16 hours, and it continuously is infused, and it has 2,000 milligrams of levodopa. And the reason it lasts 16 hours is because they've tested the stability of the compound for really 16 hours. After that, the company doesn't give you an exact time as to how long it'll last. But you could take it 24 hours if you have the need for 2,000 milligrams. Then you change the cassette in the morning, and away you go. Right? So that's the gel pack. You don't need to take anything through the day by mouth. As far as levodopa, the other drugs, of course, you have to take. You could, in the old days, which was 25 years ago when I was in residency and fellowship, we would, and still now in some patients, we would crush the tablets, right? So you can take the yellow levodopa, crush it up, it tastes horrible, but you can put vitamin C and make it into a liter of water and take little bits by mouth like this every hour. But again, absorption is here. Same problem. It gets stuck all the way here, and then it has to get down there. That's why this thing has solved that for us in a selected group of patients, but we still face the same problem of optimization that we had with DBS. So we just got a grant to do, one of our graduate students is doing this work, to use our biomechanical technology to optimize duodopa delivery. First in the lab, because we're just doing this for the first time, and then the same idea. You send the technology home with the patient, they record their biomechanical signature, and we know how much duodopa to titrate for them, so you don't have to come at all to hospital. This can be done elsewhere, right? So we won't talk about it anymore. And then the last technology that I want to talk about very briefly before we get to just a couple of slides on new treatments is tremor. This is a common problem with patients with Parkinson's disease. And it is an unmet need because tremor doesn't respond often to the oral medicines, including this home run that we were talking about, levodopa. Right? So tremor didn't respond to levodopa very well, and we had this humongous unmet need of having to put patients on levodopa to try and treat their tremor, knowing full well that there's a 50% chance that it won't work, and I'd have to increase the drug amounts to a higher level before getting any response, and maybe not get a response at all. Many of these patients didn't even need the levodopa and only had tremor. The problem with tremor, of course, is that it varies. It's like this, etc. So we again applied a technology to be able to understand where the tremor is coming from. Is it at the wrist? Is it at the elbow? Is it wrist and elbow? Is it rotation? Is it flexion extension? Is it shoulder, etc.? You can see how many movements there are in our upper limb. Even though I consider my eyeballs to be pretty good at looking at patients' tremor and saying, I think it is 30% is from the elbow, maybe 38%. It's not possible for me to do that. Why is this important? Well, it's important because we have a therapy called Botox, botulinum toxin, which allows you to inject muscles specifically and reduce their activity if you know which ones to inject. So we've been using botulinum toxin, not for wrinkles, that's a different clinic, but for treatment of cervical dystonia, people who have neck crinks like this, or blepharohemisphere, for many years, 25 years. But the problem with injection of the arm for tremor has been this visual ability to determine where the tremor is coming from. Right? And because of this, I wouldn't know which muscles to inject. And if I inject wrong, of course, the person has weakness in their hand. And so 20 years ago, 15 years ago, people tried this, not in PD, but for another condition called essential tremor, didn't have good results, abandoned. Well, we used, as one of my graduate students, Jack Lee, who now runs the company, MDDT. He's the CEO of that company where this technology is being commercialized, and it's being used actually in 6 centers in Canada and 2 in the US to do a clinical trial for treatment of essential tremor. We've just published a paper on the treatment of Parkinson's disease tremor. So these are sensors that are put on. We now have the same bodysuit technology that I showed you. That same technology has now replaced these sensors. So you can just put on a sleeve, 2 sleeves that are connected, and you can do a few tasks like this, and it records your tremor. It gives you a readout, and not only does it give you a readout, it gives you a readout of which muscles to inject. So now, even me, and I've injected thousands of people, I'm actually dependent on, or not dependent, I'm using one of my students to give me the readout for injections. And this is the technology that's being used in Toronto, and Winnipeg, and Halifax, and New York to allow us to treat. Here's a patient with Parkinson's disease with bad tremor. And they've allowed us to use their video. So bad tremor, the bottom video is running, by the way, just to tell you, this is how good the response is. Gone. Can you imagine going from that tremor to that tremor? No medications other than injection. right? So we've done 100 patients now with this technology just for tremor. Now, if you have tremor in the lower limbs, or if you have tremor everywhere, and you also have shuffling of gait and other things, you need levodopa. But there are a large number of people where tremor is their predominant bothersome symptom, and we've met that unmet need again using technology. The last few minutes, I know I've probably gone over, but last few minutes on some other technologies that you might have already known. This is patch technology. This is not levodopa. This is actually a drug called rotigotine, or Nupro patch. It is a matrix that is built into the patch. You cannot cut the patch, even though people are doing so. And sandwiched between the materials is this drug called rotigotine, which is like Mirapex or Requip, which are other dopamine agonists. You put it on and leave it on for 24 hours, right? The problem is it does give a little bit of a rash, but it is once a day, and it's long-acting, and it has significant value, again, in taking those patients that are taking lots of oral medicine and reducing that to a patch. So you can imagine, if you're taking 8 times a day levodopa, 3 times a day pramipexole, you can reduce that to a duodopa pump and a patch a day, right? That improvement in technological intervention to improve quality of life is substantial. Not in everybody, but this is where our technological advancement has improved the quality of life, yet providing already known workable therapies, right? So not inventing new things that take a lot of validation, right? There's also a levodopa patch pump technology, not the pump that I told you that goes into the jejunum, but this is a subcutaneous pump. And funnily enough, yesterday I got a call from the vice president of medical affairs from Israel of this company who wants to do, or they want us to be a center for this. I'm already kind of submerged in work, so I haven't replied yet. But this is that technology that has been developed in Israel. You can see that there's a little, almost looks like one of those things you buy at home hardware, those glue gun things. Yeah, but it's not glue. Not, you know how you mix those two. Anyway, so this is that technology, and it's inserted as a little subcutaneous thing, right? Now remember, I told you that levodopa is only absorbed in that part of the intestine, but that's if you take it by mouth. If you give it into the vessels, into the bloodstream directly, then you can bypass that completely. That means you have that entire step of absorption removed. Well, why don't we just give it IV? Well, we can't give it IV because it causes sclerosis of the veins. It'll cause a lot of pain, right? So you can't do it. Again, in the old days when I was training, we had IV pumps, and you could do it acutely for a few hours, but you can't sustain it. The veins just fall apart. This technology, and it's proprietary, so I don't know what they've done to the drug to allow subcutaneous delivery. If it was regular levodopa liquid, it'll make the skin go bad, and you can't do it. So they must have done something, but obviously they're not telling us what they've done. But this is now already gone through what we call phase 2 early pilot studies. Again, the idea is using the same compound. It's still levodopa, right? But optimizing using advanced technology, how you deliver it. You see? Yeah. So this is coming. There are no sublingual formulations of levodopa. Apomorphine, there is a sublingual formulation. At present, there's nothing in Canada with respect to sublingual formulations. There is a study that we're doing using inhaled technology. So this is, again, the same, levodopa. Instead of now being absorbed through the intestine, it's a puffer, like in asthma, right? There's a problem with the puffer, obviously, because as you, again, deliver it, you don't know exactly how much is going to sit in the pharynx, how much is going to sit in the trachea, how much it actually goes into the lungs. Why is this important? Is because unlike the intestine, where you need an actual transporter truck to take the drug across the intestine into the blood, in the lungs it just diffuses through. Yeah, so the delivery system, again, same drug. See, 3 different deliveries so far that we've talked about. Pump, puffer, subcutaneous pump. All this plain levodopa, same stuff. Different ways of delivery to optimize. So you can imagine that if you have an off period, you're in the mall, and you don't have your pill, and it's going to take half an hour, like asthma puff, you give yourself a levodopa boost. Maybe not throughout the day. And so this trial that we're doing is taking those patients that are already on oral levodopa and then giving them, in the off periods, a puff to see if that delivers. I have some concerns, obviously, as I said, in terms of just the delivery, but it has been approved through the FDA and Health Protection Environment. We've got the trial just finished through ethics, and we're recruiting as we speak for this CVT 301 inhaled technology. The last slide I think, is on a couple of other things. Again, technology, we've come back to genetics, and the proteins that are there, the alpha-synuclein, the LRRK2-related proteins, et cetera. And can we now develop treatments that will go and suck out those abnormal proteins and remove them from the system? There are a couple of trials that are going on with respect to that. Is an antibody called PRX002 against alpha-synuclein. I decided not to do this study. There was a Michael Fox-funded vaccine against alpha-synuclein. Again, I'm not impressed with the data, so we're not doing this here in terms of the vaccine therapy. It is being done in the US. So that was my last slide, and what I wanted to, as I say, take you on a journey of how we've had technological advancement through our social systems, industrial revolution in the last, you're going, thank God he's going to stop talking. Good. So, yes, it's lunchtime. And how we have actually used that technology and technological advancement to help us and guide us to at-risk populations, potentially, to identify those patients that may have had exposure from technology. But then we've used the advancements of technology, including biomechanical sensors in this, pumps and other things, to optimize treatments that are already available and, in fact, make new delivery systems such as patch technology, puffer technology through the lungs to get optimization in the patient's home, in their own environments, and also providing new interventions that take away from having to do what we've done all these years, which is continuous adjustment and treatment of patients to help with the quality of life. So technology is the future, we think, and hopefully I've provided you a glimpse of how that has happened over the last 2,000 years. Thank you very much.